Our next speaker is Associate Professor Vanessa McDonald, and Vanessa is Associate Professor in the School of Nursing and Midwifery and co-leader of the NHMRC Centre of Research Excellence in Severe Asthma and a research priority leader in the Priority Research Centre for Healthy Lungs at the University of Newcastle. She's a practicing clinician and she's working in the Department of Respiratory Medicine at John Hunter Hospital. So please welcome Vanessa.
Oops. Thank you for that introduction, and also thank you to the organisers for inviting me along today to speak about COPD and the implications that mental health disorders may have in a diagnosis of COPD, but also specifically to talk about some self-management strategies and integrated models of disease management. So let me start just by kind of presenting a bit of a health report card in Australia. So despite having lots of chronic disease, we do generally do quite well in terms of our life expectancy. So this is at 82 years and globally around the 6th highest. And in terms of smoking, we've got low rates, so around 12%. This is if you're not admitted to hospital with COPD, for example, where you're around 30. But despite this, we don't do so well in terms of COPD admissions or in managing COPD. COPD is a major problem, and in Australia it's the 4th leading cause of hospital admission. We know that it's a chronic non-communicable disease, and it's of increasing global importance. In fact, it was projected to be the 3rd leading cause of mortality by 2020, but it reached that milestone by 2010. Now, what we've known for a long time about COPD is that this is a disease that's associated with poorly reversible airflow limitation and an abnormal pulmonary response to noxious particles. So we've thought about COPD as a pulmonary disease for a very long time. But over the last many years, we've started to think of COPD a lot differently. And a lot of research has been done, and we now know irrefutably that COPD is a complex multi-system disease that's associated with a low-grade systemic inflammation and multiple comorbidities. And we also know that COPD differs from one person to another. So it presents with multiple symptoms, differing clinical presentations, and varied rates of disease progression. Previously, we assessed COPD using a measure of lung function, or FEV1, similar to the diabetes with the HbA1c. What we know now, though, is that, and I think this point was very well made in a diabetes cohort over here, is that the FEV1 doesn't actually reflect what the patient's feeling or the burden of disease suffered when you have COPD. And these data here are from a large longitudinal study that was performed internationally, where around 3,000 patients with COPD were recruited, underwent a battery of tests, and then were followed longitudinally over 3 years. And what these graphs here show are are different outcome measures, and they're more patient-reported outcome measures like symptoms of dyspnea, distance walked, number of exacerbations, and quality of life. So for each of these panels, there's 3 histograms. The top one is moderate disease to severe and very severe disease. And what these histograms show is that there are people here that have very mild disease but a huge degree of symptoms. Similarly, there are people with very severe lung function impairment who have hardly any symptoms. So it tells us that we can't look at a patient with COPD as a group, and we really need to look at individualising approaches to management. And part of that is because COPD, as I said, is associated with many complex comorbidities. So if you think of COPD as a pulmonary disease, acknowledging the extrapulmonary consequences, there are also a number of other respiratory diseases that overlap, like asthma in approximately 50% and obstructive sleep apnea. Other disorders include cardiovascular disease, and in fact, more people with COPD die from cardiovascular consequences than dying of COPD itself. Gastrointestinal diseases are also common, as is osteoporosis and skeletal muscle dysfunction. Metabolic syndromes, including diabetes, and importantly, mental health disorders, including mainly anxiety and depression. So due to the theme of this being chronic disease and mental health, I just thought I'd spend a moment reflecting on anxiety and depression in the COPD population. So these are high in terms of prevalence. However, there are a few it's a big problem is underdiagnosis. So we don't know the actual prevalence of these conditions in the COPD population. But it has been reported between 10 and 42%. And as disease severity increases, generally the incidence of depression will also increase in this population. In terms of anxiety, this has been reported at around 10 to 19%, and anxiety increases as the frequency of exacerbations increase, but also as a one-off incident of an exacerbation occurs. Importantly, in COPD, we need to recognise and really make a lot of movement toward diagnosing these conditions and ensuring that appropriate treatment is applied. Underdiagnosis and undertreatment is a major problem. In one study by Johans, they found that a quarter of patients with COPD had unrecognised clinical depression or subclinical depression, and less than 1/3 of patients with COPD with anxiety and depression were appropriately treated for their mood disorders. So it's common, but it's poorly managed. And this is really important, as you would know. But if you think about it from a COPD perspective, it also has really unfavourable impacts on disease course. This study was a study where they recruited around 1,600 patients with COPD, and they characterised the comorbidities that were present in those patients and then followed them over 4 years. And what they found is they were able to characterise all the comorbidities that occurred in COPD. They looked at the survivors and non-survivors and were able to define the comorbidities that were really associated with death. And they've represented this in this graphical image here called a comorbidome. And what this shows us is that there's lots of little circles around here. So what the circles indicate are different comorbidities, and the size of the circle indicates the prevalence in relationship to COPD. Then there's this circle here, and the areas or the comorbidities within this circle are those that were most associated with mortality. So what you find here is that depression is outside of the circle here with a similar prevalence to, say, reflux. And its distance from the star here, being the death star, is similar to that of substance abuse or CVA. However, what's really interesting is, I think, the prevalence of anxiety, which is a lot smaller than some of the other comorbidities, but it was the closest comorbidity that was associated with poor outcome, being death in COPD. So this is a condition that is common but undiagnosed, undertreated, and significantly associated with mortality. I think major improvements need to happen in terms of managing mental health disorders within a chronic respiratory disease population. There aren't a lot of data that indicate what kind of interventions work, however, and there are a lot of conflicting studies. Some say CBT is effective, others say it's not. This is one study which I thought was interesting because it was a nurse-led study of minimal psychiatric intervention based on the principles of CBT and self-management. So they recruited 187 patients with COPD, and they either were randomised to the nurse intervention or to usual care. And what they found in this study is that this minimal intervention or brief intervention was able to significantly improve depression measured by the BDI score, as well as anxiety and overall quality of life measured by the St. George Respiratory Questionnaire. So in terms of COPD then, we know that this is a common complex disease with multiple comorbidities and a lot of heterogeneity. But there are major problems with management, and we know this because patients continue to be admitted to hospital, continue to experience frequent exacerbations, and continue to have poor health-related quality of life. We did a study a couple of years ago where we recruited 100 patients with obstructive airways disease who had either COPD, asthma, or an overlap of asthma and COPD. These were older people, defined as over 55, and I apologise for that. But they underwent a multi-dimensional assessment where we characterised the disorder from a number of different domains, looking at psychosocial domains, comorbidities, risk factors, and those related to problems of the airway. And what we found in this cohort of patients that were recruited from a tertiary care institution within a respiratory clinic that had lots of support, pulmonary rehabilitation, one-on-one consults with physicians, nurses, and a multidisciplinary team of allied health professionals, that despite that, these patients continued to experience lots of clinical problems, about 11 per patient. And this impacted significantly on their quality of life. And in fact, for each additional problem that people experienced, there was an increase in the minimally clinical important difference on the SGRQ, which is a common quality of life questionnaire used in COPD. So what were these problems? So I've just broken them down here into those looking at pathophysiology, those looking at symptoms, and those looking at disease management skills. So these graphs represent the proportion that we found the problem in using this cohort. And I think the conclusions that we can draw from this, or one of the conclusions that we can draw, is that nurses have an integral role in many of these management issues. For example, if you look at symptoms and disease management skills, these are often things that either a interprofessional team of nurses dealing with mental health, COPD, potentially other comorbidities like diabetes, can all have a real role in, and we know that outcomes are successful when these interventions are delivered effectively. But there's a problem, I think, we have with delivery of interventions for people with chronic and complex diseases who have more than one condition and require multiple different types of, have multiple needs in terms of managing their disease effectively. So what works in COPD? Over many years now, there's been a big rollout of self-management programs in COPD populations, but also more recently integrated care models for COPD. And now we're transitioning again to a different type of model, which I'll speak about as well. But if we first focus on self-management, this is an interesting area in COPD, because we have data from many studies that suggest self-management interventions in COPD are effective in terms of some outcomes. But there are also studies that show self-management interventions actually have a deleterious effect in COPD. So I think the importance of systematic reviews is highlighted here in order to be able to pool the data to see what actually really works in a population. So I'm just going to present some of the results of the Cochrane systematic review that looked at self-management programs in a COPD population. So in this review, they defined self-management interventions as structured interventions for individuals with COPD that were aimed at improving self-health behaviours and self-management skills. In order to be included in this review, they needed an iterative process of interaction between the participant and the healthcare provider, and it had to be at least 2 interactions with that healthcare provider. So this is a forest plot that shows the studies that went into the meta-analysis. These squares here show the size of the effect, and if this confidence interval crosses the line in the middle, it means that it wasn't significant for that study. Down here we have a diamond that pulls all of the results, however. So what they found when they did this review is that they looked at the effect of self-management on quality of life. The St George Respiratory Questionnaire was used, that there was a statistically significant improvement in quality of life after undertaking a self-management program. Interestingly, however, when we use this questionnaire, we define a 4-unit change as clinically important. So this wasn't able to achieve the 4-unit change, but it was very close. The self-management programs did result in reduced admissions, and this went from 51 admissions that reduced to 37 admissions in 1 year. So what can we say about self-management? I think that it can be effective in a COPD population in terms of improving health-related quality of life, reducing respiratory-related hospital admissions, and improving dyspnea. However, trying to formulate recommendations on what should be in a self-management program for COPD is very difficult, because all of the studies that have been done are very different in terms of the populations they enrolled, the follow-up time, the outcome measures, etc. So we really are still in the dark a little bit about what should be involved in a self-management program for COPD. So what about integrated care? So this differs somewhat to differs somewhat to self-management, and the definition, or one definition, is that it's the provision of seamless, effective and efficient care. It reflects the whole of a person's needs, and it's across physical and mental health and in partnership with individuals, their carers and their families. So what's involved in integrated care is the patient, the clinicians and the healthcare system. So this is another systematic review that's been done in a COPD population, where they included 26 RCTs of around 3,000 patients. They were around 68 years and had 68% of males. So what we found, it included, the bell just put me off a little bit. Sorry, it's not time? That's what I was thinking, surely I haven't been going that long. So these programs needed to be multidisciplinary. So they needed to include 2 or more providers. They needed to be multi-treatment. So of these lists, the list of interventions in green, it had to include 2 components for a duration of at least 3 months. And these included things like educational self-management, exercise, psychosocial intervention like CBT, stress management or other interventions, including pharmacotherapy. And then the list goes on. When integrated care is used in COPD, it results in a quality of life improvement. This is the total score using that same instrument that I described earlier. And these are the individual domains of those questionnaires that relate to symptoms, activity and impacts. So integrated care in COPD significantly improves quality of life. However, again, didn't quite reach that minimally clinically important difference, apart from the domain of impact. Here's another forest plot, which is very small. Sorry about that. But this looks at the effect of integrated care on exercise capacity. And what it shows, if you look at the the little diamond here that pulls the results of all of these studies that measure 6-minute walk distance at 3 to 12 months, we find that integrated care models significantly improve exercise capacity. Exercise capacity is a significant predictor of mortality in COPD, so that's a fairly significant outcome. It also improves 6-minute walk distance at 12 months. However, the effect is reduced and the size of the difference is very big. 43 metres on a 6-minute walk at 12 months, 3 to 12 months, and 16 in the longer term. So integrated care models improve COPD in terms of exercise capacity. They also reduce hospital admissions, and cost-effective analyses have shown that they're also important. However, as I said earlier, we continue to have ongoing admissions, impacts in quality of life, and the cost burden from COPD is enormous. The New South Wales Health State Plan has a direction, and that is to keep people healthy, to provide world-class clinical care, and to deliver truly integrated models of health care. So what our challenge is at the moment is developing these models that will fit into the system and allow us to be able to deliver the kinds of interventions that are going to be effective. At the moment, my belief is that current systems of care are fragmented and they require a coordinated approach in order for this to work effectively. So we've looked at a model of care that where we aim to try and deliver something that was person-centred, that fitted in a system that didn't impact the patient too much, and that was individualised, looking at the actual problems going on with the patient. And this is a new area that's emerging in respiratory medicine, has been around in cancer for some time and in other chronic conditions, titled precision medicine. And how this is defined is treatment targeted to the needs of individual patients. And these targets might include genetic targets, they might include biomarkers or phenotypic markers, but importantly, they also include psychosocial characteristics and functional characteristics, clinical characteristics. And these can distinguish a given patient from another in terms of that have similar clinical presentation. So going back to those histograms I showed in the beginning, it allows us to view the patient in terms of what's going on with their individual health status. And this approach has been subject to recent reviews. However, there's little data that have tested these approaches. We, however, as I said, have designed a model where the patient is placed in the centre. Multidimensional assessment allows you to characterise what's going on with that individual, and then individualised management is then applied in order to improve outcomes for patients. Simply, this is an approach where we look at what's going on with the airway and target treatment with pharmacotherapy. Ensure that within a COPD population, comorbidities are assessed, diagnosed and managed, that risk factors are also assessed, diagnosed and managed, and that self-management is provided for behavioural aspects of the condition. I'm going to present the results of a study that tested this approach. So this was a controlled clinical trial where people were either randomised to usual care or randomised to what we call this individualised approach. They had a number of different interventions, and we targeted biomarkers. So we looked at the airway inflammation and systemic inflammation and used pharmacotherapy for that. But we also assessed their smoking status, depression, anxiety, dysfunctional breathing, hypoxemia, weight, sarcopenia, cardiac dysfunction and osteoporosis, and then designed an intervention. So whatever was going on with that intervention, a care plan was developed. The patient was included in the development of the care plan. They were asked to rate the areas of most importance to them. Their healthcare team were asked to rate the areas of most importance as well, and there was discussion about what to implement at what stage. So these are the patients. We had 30, a small study, pilot study, but 17 in the intervention and 19 in the control group. And they were around 70 years of age with moderate impairment to their lung function, moderate impairment to their quality of life, and few smokers. Their Charlson Comorbidity Index, which is a measure of comorbidity, was quite high at 4. And BMI was quite high for a COPD population. So once we delivered these individual treatment interventions, which we did in one clinical area using a multidisciplinary team, and overall patients only really needed to attend 4 visits, we found that there was a major improvement in quality of life. The studies I showed you earlier had a 4-unit change or 3.5-unit change on the quality of life scale. We were able to achieve a 14.5 quality of life change, greater than 3 times the minimally clinically important difference. We also were able to reduce the number of clinical problems that people were experiencing. So those that were receiving CBT for anxiety, for example, had reduced anxiety scores following the intervention. Those that were obese reduced their weight, etc. And overall, in the intervention group, there was a reduction in clinical problems of -3.1 within a 3-month period, and this stayed the same in the usual care group. We were able to achieve also changes to biomarkers, and this is important because it's these biomarkers that actually also predict outcome in terms of exacerbation, but hospitalization. So comparing this effect to, say, pulmonary rehab and self-management, where you get kind of much smaller impacts on quality of life, this individualised approach was able to really significantly improve the quality of life of patients by giving a combined intervention that kind of had a domino effect. By focusing on one problem, you seem to resolve a number of other problems. So in terms of keys to success in managing COPD patients with complex intervention, we need to ensure we select the right patients, and that's looking at risk stratification, participation, and ensuring that we're targeting the individual with the right treatment at the right time in the right individual. We need to ensure our interventions are effective, so look at who is going to deliver it, what we're going to deliver, and ensure we can build on interdisciplinary collaborations to effectively treat patients with chronic disease. And then again, targeting the treatment to the intervention. And we need to really look at system redesign so that we can have the funding to be able to implement effective programs, ensure our information technology works for us so that the systems speak to each other, and if one healthcare professional is seeing a patient somewhere, they've got access to that information elsewhere, and that there's effective governance. And that's all. Thank you.
I might kick off with the first question, and that's, how did you hand over back to the patient's GP, and what sort of, or general practice team, and what sort of advice did you give them to help support those changed behaviours for those patients?
I think so. So this was a study that was based in a tertiary care setting. So I think that's a really good question. The primary care providers were included from the start in terms of once we did the multidimensional assessment, that was summarised, provided to the GP with the interventions that we were going to provide, and then at the end of the intervention, the results were then summarised and provided to the GP as well. I think that was like a pilot model that was based in primary care, and what needs to happen is that we need to look at programs that can be translated into a primary care setting. that's fairly intense and will be very difficult, I think, to do in primary care, but ensuring primary care is involved in that is kind of approaches is important. And we're currently writing a grant for this round of funding to do that.
Yeah, I think I was, my name's Leslie Wilcox, I'm from Dubbo, diabetes educator, but I was actually going to pick up on that, and I suppose I'm going to voice a bit of frustration to some degree in that integrated care gets translated into so many different ways. And I'm actually working in conjunction with an integrated care program that's running in the Western area. And what integrated care means and what integrated care is talking about to one group of people, I believe one of our issues is that we don't have a consistency in that definition, and that we end up getting quite different information. I suppose, and I'm at risk of, I'm very much aware of Professor Freshwater as well. As I mentioned to her before, she gave us a good kick in the bum before lunch. But the reality is that I see integrated care as very much in the primary health, being very much involved in primary health. And I think we spend a lot of time developing models in the tertiary model that doesn't necessarily get translated very well back into primary
I agree
health.
with you entirely. I think, one, we need to speak the same language, and the review I presented around self-management very much indicates that, because people were saying they were doing self-management, but when you pulled all the studies, they were all so different and meant something different to each of the different designers of those studies. So we do need to kind of speak the same language. And in terms of integration, I think that's really important as well. And I think, this was a pilot study, and we need to kind of start somewhere to test the proof of concept. But then rolling it out and ensuring it's a cross-disciplinary program is really important. And work has been done on that, particularly in Spain, looking at integrated care for COPD. And what they were able to show is that, where primary care was very much involved in that, they took a tertiary program and then they placed it in a primary care setting, did some tweaks so that it worked in that setting, and it was equally effective. And the cost shift was also really high. I think 17% of the costs were shifted from tertiary care into community, but those costs were different. So it wasn't the high cost of hospitalization, etc. So it's a very valid point.
We could just thank Vanessa again. Thank you.